I'm going to just go through some information and some data here that I've compiled the recent COVID data. So if you can flip to the next slide. So this is Illinois daily cases, a 7-day average. And particularly need a 7-day average now because now we are no longer reporting on the weekends or holidays because COVID's not that bad. It's so bad we have to mandate vaccinations and masks, but we don't have to report every day. So the 7-day average gives us much better than a 1-day spike after 3 days of nothing. So as you can see, we are in fact in a time of some rising COVID cases as we have been in the past. Early on you'll see we had no testing, so there was really no way to identify cases. I think we probably pretty much everyone would agree that those cases were higher than they were at any other point in this. But I think what's important here is we had a mask mandate that started where that arrow is on the left, and it ended where that arrow is on the right. You notice the spikes we had in between there with masks, with a mask mandate in place. Those are the spikes we had. Now we put in new mask mandates for the schools. At the second arrow from the right, that's when the mask mandates for schools went in. And as you can see, cases have gone up. And then the new mask mandates that went in recently as well. Flip to the next page. The good news is deaths related to COVID are not rising as fast as cases. So I think that could be for a number of reasons, including mutations of the various types. Also, because COVID tended to go after those people who had the weakest immune systems first, but also because we have much more effective treatments now. We've learned more about it, and we're treating this more effectively. So all of those things are good things. So you can see what happened, and again, it kind of highlights where the mask mandates were. The other thing that's important here, and I didn't mention on the last slide, is that back in last October 2020, we no longer just counted cases that were actual cases. We also counted cases that were probable cases, which means if you had any symptom that was a COVID-like symptom, even if not tested, so you could have had the flu, you could have had a lot of other things, it counted as a COVID case by this. Same thing with the deaths. We have probable COVID deaths as well. So I'm not exactly sure what that means, but that's part of what's counted here. And this is directly from IDPH. Flip to the next slide. So you've seen this before. These are cases by age. So the trends over the last 75 days, since we've heard about the Delta variant, how it's impacting kids, is pretty much the same. If you look at the cases by age, June 24 to September 3rd, relative to on the left is all cases since the beginning, suburban Cook County, not the city, everything that's in the suburbs. And you can kind of see that the trend lines are pretty much the same as far as where the cases are coming from. And you'll also notice that the under 20 group is obviously the highest population group as well, because you've got 20 years and they're all younger, whereas well, over 80 is a lot of years. There's not as many of those people that are still here. Flip to the next slide. So we've heard a lot about hospitalizations, and kids being hospitalized, and this was the reason for mask mandates in schools. These are the hospitalizations by age on the left side since the beginning in suburban Cook County, and on the right side, this is since August 15th to November 3rd. So when schools went back in session till now, you can see under 20 is 16, 20 to 29. So really the trend line is very similar. Even though a lot of the people under 20 are not eligible for the vaccine, you can still see those numbers are very low. And even though over 80 is very eligible for, most of them are, overwhelming majority of them are vaccinated. You're still seeing that the numbers are pretty high. So I just want you to see the facts and the data, because it's out there for people to get, just like I did. You have to pull it all together, and you have to track it every day in order to know what this is, because they do it in total. So what we're trying to do is track it every day and get you the facts so that you see them. Flip to the next slide. The good news is, if you recall, we had, from March to June of 2020, the hospitalization rates were about 20%. That's what we kept hearing about. 20% of the cases were ending up in the hospital. Well, since the very beginning now, since March all the way till now, it's only 7.1%, because it's gone steadily down. Since June 23rd, it's 5.6. So we're seeing far fewer, a little over 5 cases per 100 now go to the hospital as opposed to 20. So, obviously good news for that. Also the mortality rate, so 1.67% since the beginning March to June of 2020, it was actually 1.56, so it kind of spiked a little bit after June. It got a little bit higher than that, but June 23rd till now, the mortality rate's 0.6. So what we're seeing is that just like we saw with the numbers before with deaths, you expect that to be lower. So we're seeing a much lower percentage of people that are actually dying from this when they get it. So all good news. It means we're treating it more effectively. Probably also means there's a good chance the vaccine's having a positive impact. So those things are having a positive impact. So flip to the next slide. One thing we've heard for the need for all this and the justification for all this is how COVID is overrunning our hospitals again. It's simply not true. 7.2% of all hospital beds as of today in Illinois were COVID patients, 7.2, so 7 out of 100. ICU beds 17, ventilators 5.4%. So it is true that COVID cases are up. There's more COVID cases in the hospital, but they are not overrunning our hospitals. The other hospital beds in use, I think there's about 20% are not in use. So there's 73% that I don't know what we're doing to mitigate for that 73%, but we're doing all our mitigation for the 7. So I think that's an important fact to note. Next slide. So we're talking about emergency orders here because our legislature has not acted. And the way that our Constitution works, our legislature is supposed to act. One of the reasons we're doing this, I know a lot of places decide to stay silent and they just don't enforce. We're bringing this to the public because the public deserves to hear us discuss the policy and vote on the policy, because that's the way our form of government works. It's not a policy that's set behind closed doors and we just do it, we discuss it. So the state of Illinois, we've been under a state of emergency for 600 days, over 600 days. And during that time, 97 executive orders. Now, over on the left, you'll see how many executive orders we've had by year. Okay? So we're ruling by fiat and by one man. We're not ruling by legislative action. I can understand it being a little spiked in 2020 because of what happened for a month or two, but there's no excuse for the legislature to not act. None. They've abdicated their responsibility. And frankly, while I may disagree with the governor's actions, if the legislature doesn't act, he has to do something. He makes a decision on what to do if the legislature doesn't. The legislature should be acting. Now, to the right is a smattering of the various executive orders. Okay? I think it's important to note those that are highlighted there really have nothing to do with COVID. Okay, so why are we doing these items when the legislature can certainly act? For example, requiring electric vehicles across the state of Illinois fleet within 10 years. So let's think about that. We've mandated that 2 nuclear power plants are going to come offline, which are going to devastate those communities. It's also the most clean energy source that we have is nuclear energy. So we're taking all that electricity offline. Now we're going to put all this electricity demand back onto the grid when we've taken all this power offline. I'm not exactly sure where it's going to come from. Then we're going to put all these electric vehicles, and anyone that knows anything about the grid knows that it's not overbuilt. So when we add all those electric vehicles to the grid, we're going to have to somehow find a way to get supply to those vehicles. Now that's going to require a partnership between ComEd and Illinois. I'm sure that's going to go really well, like it has for the last 10 or 20 years. So that's what we're relying on. Okay. We also created a statewide office of equity. We created a Welcoming Illinois office and a community advisory council on homelessness. These create new positions in the state that aren't budgeted, that someone's got to pay for. So where is the legislature on this stuff? I pointed that out. Next slide. Oh, wait, back to that slide. I'm sorry. I forgot. You don't have to go back. You can leave it. I'll just comment on it. Keep in mind the school mask mandate that went into effect gives ISB and IDPH power that it does not have. And the Senate considered giving them that power to control our schools in Senate Bill 2789. They voted it down. So they didn't give them the power. Then the governor said, well, I'm going to give it to them anyways. That's not the way our government works. Now there's a House bill that's contemplating the same thing that is yet passed. If the state legislature wants to give ICYMI and IDPH that power, then they should do so. But when they choose not to do so, and they actually vote and choose not to do so, and then the governor just says, well, I don't like your ruling, so I'm going to do what I feel like, that's not the way it works. I don't think our board here would appreciate if I did something like that. So that's what happens. So flip to the next slide. So there's a lot on this slide, okay? And the reason I'm doing this is because we've heard a lot about masking and vaccinations and studies and not studies and blah, blah, blah. Okay, I did a ton of research trying to find studies on masking. Okay, so masks have been mandated, again, with the claim that this is based on science. We've asked for the science repeatedly. We've yet to see it. I want to point out that the NIH and the CDC have performed no randomized controlled test studies on masks. None. Okay? We're 19 months into this. They get billions of dollars of funding. You would think that would be an important study to do. Okay? They've done 15 observational studies. Observational studies are anecdotes, right? Observational studies are where you look at what happened in something, like they like to use the one where there were two hairdressers and they were masked, they had COVID, no one else got COVID. But that's not really determining whether or not, that's just an observation of that particular incident. We can point out, and I can point out an instance where the 6 people that were masked at one restaurant, the 6 servers and nobody else was, they got COVID and no one else did. It'd be just as bad to draw a conclusion from that, because we need these randomized controlled tests. That's exactly what we do for our pharmacies, for our vaccines, is we do these tests. So why are we not doing these tests? And the reason why is because you get biases. You get biases on what's exposed and what's not exposed because there's no control group, okay? So neither of them have done one of these tests. However, prior to COVID, there were 12 studies around the world that have tested the effectiveness of surgical masks in reducing the transmission of respiratory viruses. One indicated a 10% lower infection rate with masks and hand washing than hand washing alone. Okay, so it was statistically significant. The 11 others showed no difference in infection or higher infections with masks than hand washing alone, believe it or not. So definitely not anything super conclusive here. Prior to COVID, there was one randomly controlled test study studying cloth masks versus surgical masks. Now there was no control group with no masks. It was just cloth versus surgical. And the study showed that cloth masks had a 2.28 chance of developing flu-like illnesses compared to a 0.17% of surgical masks. So it certainly shows that there is a statistical significance there relative that cloth masks are not as good as surgical masks. I think that's a conclusion that can be drawn there. There was a Danish study of 4,800 participants done for COVID versus surgical masks versus no masks, and there was no statistical difference. Again, I just question why NIH and CDC haven't done some of these tests, because they could actually do these tests. All of this fighting over masks could be gone if they would just do some real scientific tests, and they had 18 months to do it. A study published in the Physics of Fluids journal studied the filtration effects of masks. So they looked at N95. It had a 60% filtration of small particles. KN95, 46%. Surgical mask 12.4%, and 3-ply cloth mask 9.8%. So not surprisingly, N95's much more effective than surgical masks and 3-ply masks. These are the only studies I could find that are out there. So, but I felt like we needed to bring those to people's attention so that you had the information. And I guess the real question I have, given that we've had 19 months, is why haven't the NIH or CDC, or for that matter, even the state of Illinois or the state of Texas or the state of Florida, they certainly have the funds to do a test like this. Why have we not done that? It seems to be critical for public health to get us that information and do some real quality studies. We've done them for the vaccines that we've approved. Why couldn't we do them for something else that so many people are mandating? Are they effective or are they not? Flip to the next slide. So here's an example of an observational study. Japan, I think we all know, is one of the most mask compliant countries in the world. This is their cases, daily cases, dating through today. So you can see the spike they're having, and they're very mask compliant, okay? But again, it's an observational study. It's not a scientific study because there's a lot of other factors going on there that we're not controlling for. Flip to the next one. Australia. Again, another observational study. Well, we know they've been locked down since the end of June. Most of that country's been in a complete lockdown. Look what's happened since the end of June with their cases. What's causing that? Again, this is simply an observation. You can't make a judgment because you really haven't identified the factors. But that's my point. My point is you can pick stuff on either side when you just use observations. So we need real studies. Flip to the next slide. So Illinois itself, we showed this before. We've had several surges while we're under a mask mandate. Flip to the next slide. So now we get into the vaccine. And I felt this was important because, I think it's important to have the facts as you do this. From 2010 to 2020, the median time for a vaccine approval from the FDA was over 9 years, 8 years in clinical trial and 12 months to review it. That's the median. The 25th to 75th percentile you see there, so that's about roughly 7 years to roughly 13, okay? So that's where over half of those that were approved were between 7 and 13 years. So that's actual vaccines that were approved. Flip to the next one. So we approved one in a little over a year, okay? And I will say today, I am thrilled that we had an emergency use authorization with this thing as fast as we did because I'm sure it saved lives, particularly those people who are in the vulnerable populations, okay? These are the phase 3 trials of those 3 drugs that were approved. So these are the actual numbers from the phase 3 trials. They all had, each of these groups that you see there, the placebo and vaccine had at least 14,000, some went up to 20. But they at least had 14,000. So these were big, big trials. Obviously, because so many people were taking it, it was easier to get a big trial. So this is a phase 3 trial. By the way, for Pfizer and Moderna, the mRNA vaccine, an interesting fact, it's the first mRNA vaccines ever to go to a phase 3 trial. Okay, so they've never gone this far. The Johnson & Johnson, that particular vaccine technology has been around since the 60s and has many vaccines that use that technology. So 1.31% of Moderna's, the placebo, contracted COVID compared to 0.08% of Moderna with the vaccine. So definitely statistically significant. They all are statistically significant. Pfizer, 0.84 to 0.05, J&J, 1.78 to 0.59. And clearly these were done in different times and in different places. J&J was done throughout the world, so which could result in potentially having higher placebos even getting it. So, but they were all the placebos and the vaccines were all done at the same time in the same places, which is what makes it controlled for that group, which is how we test vaccines. Okay, so all of these are statistically significant. So I think it's great that we gave it an emergency approval. What concerns me is how fast we've gone to a full approval, and I think anyone who's paid attention to drugs and drug approval times, they are tremendously long and probably way too long, particularly for a lot of diseases. We should have that discussion about whether or not to make this process faster, but the discussion of making the process faster and approving these vaccines should be separate. We should decide on the process first, how to make it faster, then apply it to this. Not roll it all together and never really have the process discussion, which we haven't had. But again, these have clearly saved lives, and they clearly, have a positive impact. And I again recommend people go to their doctors and determine what they want to do with that. Flip to the next slide. So recently we've mandated a vaccine by the governor using his emergency powers. Okay, here's the population. This comes from the IDPH site. The Illinois percent of vaccinated over the age of 16. 70% of our population is vaccinated. Over 65, which we know is the really at risk, 86.5%. The people in Orland Park over 16 that are vaccinated, 89. Now, in fairness, this includes people that just got one shot of the series because IDPH doesn't break it out. But look at that. 9 out of 10 over the age of 16. Why are we mandating a vaccine that almost everyone has taken already? I don't understand, as something that was just approved. One man, and we have certainly approved vaccines before and mandated vaccines before, but the legislature has done it. In fact, the legislature with chickenpox was, the vaccine was approved in 1995, and I don't know if anyone remembers, there was a lot of angst and discussion and very difficult discussions when this was approved by the legislature in 2002. So 7 years after it was approved, it was already on the market. In fact, my kids already had it at the advice of our doctors before it was mandated in 2002. So it went through like a 7 or 8 year total trial time. Then it was approved. Then it's another 7 years, and then our legislature voted to mandate this. Not one person. That's the key here. And again, when I talk about why is it mandated, look at how many people are vaccinated, look at the Illinois beds due to COVID. So to me, that's very concerning, why one man is doing that. Flip to the next slide. So in my opinion, and this isn't data, this is just Keith Pecaw's opinion, having looked at this a lot. There's a lot of information that would help us make decisions. It would help you make decisions. It would help the public make decisions about this disease and what to do, whether to vaccinate, and what to do for themselves, right? We should be tracking for every case, age, whether they're vaccinated or not. Then we would know which vaccines are ending up in the hospital, which ones are ending up sick. We would know how well these vaccines are working. When was the vaccine given? So we would know if a booster is necessary or how long it's lasting, etc. These things are things that we would know. We would know potentially if it does, what variant. We would know whether or not it was working against one variant and not another. These would all be important pieces of information. What industry they work in. Remember, we shut down restaurants. Restaurant workers weren't getting this at an abnormal rate. If 80% of your cases were restaurant workers, well, now you might actually have a case to say, maybe we need to do something with restaurants, right? Or teachers, or whatever the case may be. What are the symptoms that people are getting? What are the comorbidities that they have? Were they hospitalized or not? What treatments were given? Did they end up in an ICU? Were they on a ventilator? Did they recover or did they not? All of that data, if given to us, can help us make some really good, data-driven, fact-based decisions. And we're getting none of it. And in my opinion, either if we're not asking for it, it's complete incompetency. If we have it because we've asked for it and we're not releasing it, then you're not being transparent to the people and you're being corrupt. So that's my personal opinion. So there's the data, and now we can have a discussion around it. So any comments?
Mr. Chairman.